Before I begin, I'd like to acknowledge the traditional owners of the land on which we work and learn, and I'd like to pay my respects to their elders, past, present, and emerging. So an overview of my presentation, I'm going to talk about the definitions, epidemiology, etiology, presentation, anatomy, assessment, and a little bit about the management of posterior shoulder instability. So there's a key distinction between instability and laxity. Instability is reserved for symptomatic shoulders. It describes a pathological joint translation that causes symptoms, or an inability to keep the humeral head centered during active range of motion. Laxity, on the other hand, is a specific translation for a particular direction or rotation, and patients may be asymptomatic despite significant laxity. Glenohumeral instability affects about 2% of the population, and only a very small subset of these patients, about 2 to 5%, will experience posterior instability. Posterior dislocations account for only 4% of all shoulder dislocations. 50% of cases are missed on first examination, and about 50% of the cases are caused by trauma. So looking a bit closely about the etiology, so you can break it down into traumatic or atraumatic. Patients with a traumatic history may have a single traumatic event with the arm in a high-risk position, which is flexion, adduction, and internal rotation. And this accounts for 50% of cases. Another group will have repetitive microtrauma, and this is patients, usually sports people, such as American football linemen, weightlifters, overhead athletes, swimmers, and rowers. And then we have the traditional history, textbook history of electric shock and seizures. This occurs due to muscular tetany. On the other hand, we have our atraumatic group, and this is patients with a collagen disease, a bony abnormality, or generalized ligamentous laxity. Patients will often present with vague symptoms that are diffuse and without a single traumatic event. Most commonly, they report deep pain within the shoulder at the posterior aspect, as well as reporting weakness or worsening of athletic performance. Less commonly, they'll describe mechanical symptoms such as clicking, popping, giving way, or slipping. As we all know, the shoulder is the most mobile and least stable joint. Less than 1/3 of the humeral head articulates with the glenoid, and there's both static stabilizers and dynamic stabilizers. And I'll go on to describe those in further detail. Looking at your static stabilizers, there's the bony congruence, and this is affected by the glenoid version, the glenoid surface area, and the humeral head retroversion. The glenoid labrum works to deepen the glenoid and increase the surface area. It's an anchor for the capsulo-ligamentous structures. It contributes to the concavity compression stability and assists in maintaining an intra-articular negative pressure. If the labrum is resected, the glenohumeral stability decreases by 20%. You also have your glenohumeral and coracohumeral ligaments. These provide static stability at the end of range of motion. Particularly important is the superior glenohumeral ligament, which is this one here, the coracohumeral ligament, this one here, and your inferior glenohumeral ligament, including the anterior band and the posterior band. So your superior glenohumeral ligament and your coracohumeral ligament, they limit the inferior translation with the arm in external rotation and adduction. That they limit inferior translation and external rotation with the arm in adduction. They also limit posterior translation in flexion, adduction, and internal rotation. The inferior glenohumeral ligament has both the anterior and posterior bands, and it's the main restraint to posterior translation with the arm in abduction. The capsule is thinnest in the posterior aspect. It's about 1 millimeter or less. It may limit posterior translation when the arm is flexed, adducted, and internally rotated. And it's vulnerable in American football linemen when they are blocking, as this is a common position that they're in. The rotator interval is bordered by the supraspinatus, subscapularis, coracoid process, and the biceps. Its role in stability is quite controversial. The rotator interval is reinforced by the superior glenohumeral ligament, the coracohumeral ligament, and the middle glenohumeral ligament. It's possible that it may limit inferior and posterior translation when the arm is in adduction and external rotation. Now looking at your dynamic stabilizers, you have the rotator cuff. It provides a concavity compression force. The subscapularis is the primary dynamic stabilizer in posterior translation. Your supraspinatus prevents inferior instability, and your infraspinatus and teres minor act as posterior compressors. Your periscapular muscles coordinate scapulothoracic motion, and this includes your trapezius, your serratus anterior, teres major, and latissimus dorsi. The long-headed biceps may have a role in inferior instability. So there's some key things to establish in your assessment. First one is the direction. So does the patient have unidirectional or bi or multidirectional instability? The degree of instability. So patients may have mild subluxation to frank shoulder dislocations. The cause is important to establish. And also the volition. So some patients will be able to voluntarily reproduce their symptoms. There's two separate groups here. One is the habitual posterior instability. So these are patients that, when the arm is adducted, can voluntarily sublux or dislocate the shoulder. And this is due to a muscular imbalance. And the other group is the positional posterior instability. So these patients usually will have instability when the arm is flexed and adducted, and they can voluntarily reproduce this instability, but often these patients will avoid that position. In terms of your examination, so palpation, patients may have posterior joint line tenderness. Their active and passive ROM is usually normal and symmetric, as well as their power. It's important to look at the scapulothoracic motion and make sure there's no scapular winging. And patients should be assessed for generalized ligamentous laxity. So you can do a Baton score. There are a number of special tests that are relevant in posterior shoulder instability, and I will go through all of those in detail. The first one is the jerk test. So this is with the patient upright, with the arm and elbow flexed to 90 degrees and with internal rotation. The posterior shoulder girdle is stabilized and pushed anteriorly, whilst the elbow is pushed posteriorly. This causes the humeral head to subluxate posteriorly, and then the arm is extended, and as the arm is extended, a clunk is felt when the humerus reduces. The test is positive when you get a sudden jerk and the patient feels associated pain. Next test is the Kim test. Again, the patient is upright. The arm is in 90 degrees abduction. It's then elevated to 45 degrees whilst applying a downward and posterior force to the upper arm. This test is positive if the patient experiences a sudden onset of pain. All right. Now, Kim et al. Did some research seeing the effectiveness of these two tests in detecting posterior inferior labral lesions. The Kim test was found to be 80% sensitive and 94% specific. The jerk test was 73% sensitive and 98% specific, but when the two tests were combined, their sensitivity increased to 97%. So you have your posterior stress test. So this is with the patient supine, with their arm flexed to 90 and internally rotated. A posterior force is applied through the humerus. This test is positive when subluxation is palpable or observed, and the patient has reproduction of their symptoms. The load and shift test. In this case, the patient is upright. The humeral head and proximal humerus is grasped and compressed into the glenoid, and then an anterior and posterior stress is applied. The direction and degree of translation is graded, and 50% displacement is the upper limit of normal. Finally, the sulcus sign. Again, the patient is upright, the arm is put in a neutral position, and a downward traction is applied. The distance between the graded tuberosity and the acromion is measured, and if it's more than 2 centimeters, it's suggestive of multidirectional or inferior instability. Now, looking at investigations, so patients should have plain radiographs, they should have a true AP of the scapula or a Grashy view with the arm in neutral, internal rotation and external rotation. Should have a transscapular or Y view, and the axillary view is probably most useful in assessing the joint congruency and whether the shoulder is enlocated. CT is very useful to assess bony morphology. It's useful to looking at the version of the glenoid, whether there's any glenoid bone loss, and also looking for subtle fractures. It also can determine whether there's a reverse Hill-Sachs lesion. MRI is useful for soft tissues and should be done to look at the assessment of the posterior labrum, the capsule, and other soft tissues. On your X-ray, the typical finding is your light bulb sign. So there's a rounded appearance of the humeral head, there's loss of the normal half-moon overlap between the humeral head and the glenoid, and there's widening of the glenohumeral joint space. On the left here, you can see an MRI showing a posterior labral tear. In the middle, there's an axial CT scan demonstrating a reverse Hill-Sachs lesion. And on the right, we have the 3D recon from a CT showing a reverse bony Bankart with posterior inferior glenoid bone loss. Now moving on to your management. So most patients will be suitable for conservative management, and these are the ones with atraumatic instability. Physiotherapy is directed to strengthen dynamic muscular stabilizers, particularly the posterior deltoid, your external rotators, and your periscapular muscles. Patients can do activity modification, and their conservative management is particularly useful in those with generalized ligamentous laxity. The indications for surgery is unclear. There's no clear guidelines. Patients who have a single traumatic instability event are at high risk of recurrence, and these patients might be appropriate to proceed straight to surgical intervention. Otherwise, it's appropriate for patients who have failed conservative management or those who have a very identifiable soft tissue or bony pathology. There are a number of different surgical procedures that you can do. When making a decision, it's important to assess the glenoid bone loss. Again, there's no clear recommendations about what degree of bone loss warrants osseous augmentation. If we extrapolate from the literature on anterior instability, it's possible that more than 15 to 20% warrants osseous augmentation. Your procedures can be done open or arthroscopically. In the case of an open procedure, there's an increased surgical site morbidity. The axillary and suprascapular nerve are at risk in your dissection, and this sort of procedure as the procedure being done openly is more common when you're doing an osseous procedure. Arthroscopically, there's less morbidity, there's improved cosmesis, less pain, but it may be more technically challenging. The type of procedure depends on the pathology. Some patients will be suitable for just a capsular shift or plication with sutures. You can do a posterior stabilization and label repair. An opening wedge glenoid osteotomy is suitable for those with a retroverted glenoid. In those with significant posterior glenoid bone loss, you can do a posterior bone graft, and in patients with a large reverse Hill-Sachs, you can do a subscapularis transfer. Just a bit more detail about the arthroscopic stabilization. It can be done in beach chair or a lateral position. The lateral position may be favoured by some surgeons as it allows easier access to the inferior and posterior quadrants. You can do a simple posterior capsular application with sutures or a labral repair with suture anchors. Important to note, the axillary nerve is in very close proximity to the glenoid rim in the 6 o'clock position. One study showed that it was only 12.4 millimeters away, and it's a good idea to avoid diathermy in the inferior glenoid and just be aware that the nerve is in very close proximity. It remains controversial whether to close the rotator interval. Postoperatively, these patients are immobilized for 4 to 6 weeks. They're told to avoid internal rotation and they begin active range of motion after 6 weeks. I thought this procedure was particularly interesting. So this is a distal tibia allograft used as an anatomic intra-articular bone graft. The distal tibia has a good anatomical congruency with the glenoid. Previously, they used iliac crest bone autografts, but obviously there's some donor site morbidity. When doing these bone grafts, the placement is really important, so it's important to make sure it's not too medial, or there will be an ineffective stabilization and the bone graft will not effectively improve the articular arc. And if the graft is too lateral, there's a risk of impingement and shearing, leading to cartilage erosion. Now, this is one of the JOS articles by Frank et al. That proposes a treatment algorithm for posterior instability. If we go down the left-hand side, it's looking at patients who have multidirectional instability or generalized ligamentous laxity, and these patients are referred for physiotherapy rehab. On the right-hand side, it's those with isolated posterior instability and have recurrent symptomatic posterior instability. If these patients don't have shoulder pain or they're medically unfit or have voluntary habitual instability, these patients are referred for physio. On the other hand, there's your patients with posterior shoulder pain. Right. This is a JOS article by Frank et al. That proposes a treatment algorithm of posterior shoulder instability. On the left-hand side, there's those patients who don't have symptoms of unidirectional instability but have multidirectional instability or generalized ligamentous laxity. And these patients are referred for rehab and physiotherapy. On the right-hand side, you've got your isolated posterior instability and your recurrent symptomatic posterior instability. Those without pain, those who are medically unfit, or those who have voluntary habitual instability, they're referred for physiotherapy. The patients with shoulder pain, sensations of instability, a positive Kim test, these ones in their practice are referred for surgery, depending on the degree of glenoid bone loss. So with minimal bone loss, they undergo an arthroscopic labral repair with posterior inferior capsule application as needed. With moderate bone loss, it's again done arthroscopically, but they consider a bony augmentation. And in those with 20% or more bone loss, they'll consider an open procedure and they will do a bony augmentation with an iliac crest bone graft or an allograft. Postoperatively, patients can develop stiffness with a loss of internal rotation. There is a risk of nerve injury as a complication, and patients may develop degenerative joint disease. There's a lack of robust literature on posterior shoulder instability. This is probably because it's a very infrequent condition and there's even lower numbers of patients undergoing operative management. And there's a significant heterogeneity between the studies, which makes it difficult to draw conclusions from meta-analyses. But looking at the literature, about 60% of patients will return to their previous level of sport, but obviously there's significant variation between the studies. The rates of recurrence is about 3.5% to 19.4% with surgical intervention. Longo et al. Did a recent systematic review in 2020, looked at 847 shoulders, and the redislocation rate was 8.7% in those who had a soft tissue abnormality versus 9.1% in those with bony abnormalities. Interestingly, the throwing athletes are less likely to return to their previous level of play. So in summary, it's a rare condition. Patients often have a vague presentation and it is a commonly missed condition. Clinical examination is important in the diagnosis. Conservative management will be appropriate in most cases. And if undergoing surgical management, it should be tailored to the patient on a case-by-case basis, depending on the patient's pathology. There are fairly low rates of recurrence post-operatively and there's modest return to sport. But we certainly need more high-quality research in this area. Here are my references, but thank you for listening.